Code Blue, room 302. Code Blue, room 302. You hear those words echo through the ICU, and your heart starts racing. You rush into the room and see a patient in severe respiratory distress. Their oxygen saturation is plummeting, they're struggling to breathe, and you know what's coming next. The physician looks at you and says, those four words that can make or break a patient's outcome. It's time to intubate. Hey everyone, my name is Neil Brian Galvin, this is NurseBrain. And if you've ever felt that pit in your stomach when you hear those words, or if you've wondered what exactly happens during this life-saving procedure, then this video is for you. Here's the thing, intubation isn't just a medical procedure, it's literally the difference between life and death for your patient. As an ICU nurse, you're not just a bystander in this process, you're an absolutely critical part of the team that makes it successful. In the next 15 minutes, I'm going to walk you through everything you need to know about intubation. We'll cover when and why we intubate, the step-by-step process, your crucial role as a nurse, potential complications, and the monitoring that happens afterward. By the end of this video, you'll have the confidence to assist in any intubation scenario. But before we dive in, if you're serious about mastering critical care nursing, hit that subscribe button and ring the notification bell because we're about to get into some life-saving content that could make it all the difference for your patients. So, let's start with the basics. What exactly is intubation? Intubation is the process where we insert a breathing tube called an endotracheal tube or ET tube through your patient's mouth or nose, past their vocal cords, and directly into their trachea. Think of it as creating a secure highway for air to get to the lungs when the patient can't maintain their own airway. Imagine your patient's airway is like a tunnel that's about to collapse. Intubation is like putting a strong support beam, the ET tube, inside the tunnel to keep it open and functional. Now, this isn't just one size fits all. We have different sizes of endotracheal tubes, typically ranging from 6 to 9 millimeters in diameter. Women usually get a 7 to 8, while men typically get an 8 to 9. The tube has a small balloon at the end called a cuff that we inflate to seal the airway and prevent aspiration. But here's what most people don't realize. Knowing what intubation is just the beginning. The real action is, when do we actually need to do this life-saving procedure? Picture this scenario. You're monitoring your patient when suddenly their respiratory rate drops to 6 breaths per minute. Their oxygen saturation is 85% despite high-flow oxygen, and they're becoming less responsive. This is exactly when we need to intubate. There are several critical situations that require immediate intubation. First, respiratory failure. When your patient simply can't get enough oxygen or can get rid of carbon dioxide effectively. Second, loss of consciousness or decreased level of consciousness where they can't protect their own airway. Think of stroke, overdose, or severe head injury. Third, airway obstruction. Something is physically blocking their ability to breathe. Could be swelling, trauma, or a foreign object. Fourth, before surgery, when they need to be completely unconscious and paralyzed. Fifth, cardiac arrest. During CPR, we need to secure that airway immediately. I remember one patient who came into after a car accident. He was conscious and talking, but within 30 minutes, his face started swelling from the trauma. His airway was closing off rapidly. We had maybe a 5-minute window to get that tube in before we'd lose the airway completely. That's the reality of emergency intubation. Sometimes you have minutes, sometimes you have seconds. But knowing when to intubate is only half the battle. What happens next is where your skills as a nurse become absolutely critical. Alright, here's where things get real. When the call comes to intubate, you become a part of a precision team, and every second counts. Your first job? Preparation. And I mean fast preparation. You need to get the crash cart in the room immediately. Ensure IV access. If they don't have one, get one now. Set up the bag valve mask with 100% oxygen. Get that suction ready and turned on high. Have your medications drawn up and ready. Speaking of medications, you guys, you'll typically see three types: a sedative like etomidate or propofol, a paralytic like rocuronium or succinylcholine, and sometimes an analgesic like fentanyl. Know these drugs, know their doses, and have them ready to push fast. Your second critical job? Monitoring. During the intubation, you are the eyes and ears for the team. You're watching that monitor like a hawk, calling out oxygen saturation levels, heart rate changes, blood pressure, any arrhythmias. SATs are 92%, 88%, 85%. You need to be loud, clear, and continuous with these callouts because the person intubating is focused on getting that tube in and may not be watching the monitor. Third job, patient positioning. Get that bed flat, raise it to the comfortable height for the provider, and if there's a removable headboard, take it off. The patient's head needs to be in a sniffling position, slightly extended, like they're trying to smell something above them. Now, here's what happens during actual intubation. Pre-oxygenate with bag valve mask. Medications are given, sedative first, then paralytic. The laryngoscope goes in to visualize the vocal cords. The 80 tube is inserted through the cords. The cuff is inflated. We confirm placement. And here's something crucial during those 30 to 60 seconds when they're placing the tube. The patient gets no oxygen, zero. That's why your monitoring is so critical. If those sats starts dropping into the 70s or 60s, you need to speak up immediately. But getting the tube in is just the beginning. What happens next determines whether this intubation was successful or if we're about to face some serious complications. This is the moment of truth. The tube is in. But is it in the right place? Because if it's not, we have minutes before this becomes a life-threatening emergency. First confirmation method. End-tidal CO2 detector. This little device changes color when it detects carbon dioxide. Purple, that means no CO2. That's bad. Yellow means CO2 is present. That's what we want to see. Second method. Listen to breath sounds. Equal breath sounds bilaterally over the lungs and no sounds over the stomach. If you hear gargling over the epigastrium, that tube might be in the esophagus. Third method. Watch for equal chest rise and fall. Both sides should move together. And the final confirmation, chest x-ray. The tip of the ET tube should be about 2 to 3 centimeters above the carina. That's where the trachea splits into the right and left main bronchi. Let's talk about what can go wrong, because complications happen and you need to be ready. Esophageal intubation. The tube goes into the food pipe instead of the airway. This is a medical emergency. The patient gets no oxygen and you'll see those SATs plummet fast. Right main stem intubation. The tube goes too far and only ventilates the right lung. You'll hear breath sounds only on the right side. Aspiration. Stomach contents come up and go into the lungs. This is why we suction and why positioning matters. Cardiovascular collapse. The medications and positive pressure ventilation can cause severe hypotension. Have that fluid bolus ready. Here's something they don't teach you in school. Failed intubations happen, even to experienced providers. I've seen situations where we've had to bag mask ventilate between attempts, call for backups, or even consider a surgical airway. Your job is to stay calm, keep monitoring, and be ready for whatever comes next. But once we confirm that tube is in the right place, your job shifts to something equally important: ongoing monitoring and care. Congratulations, the tube is in. It's confirmed and your patient is now on ventilator, but your work is just beginning. First priority, ventilator settings. You need to understand the basics. Tidal volume, usually 6 to 8 ml per kg of ideal body weight. Respiratory rate, typically 12 to 20 breaths per minute. FiO2, fraction of inspired oxygen. PEEP, positive end expiratory pressure. Watch out for the video on Saturday where I'll be discussing your mechanical ventilation setting. Second priority, continuous monitoring. You're watching oxygen saturation and tidal CO2 levels, peak inspiratory pressures, minute ventilation. Third priority, tube security. That ET tube needs to be secured properly with tape or a commercial device. Note the depth at the teeth or gums, usually 20 to 24 cm for adults. If number changes, the tube has moved. Fourth priority, patient comfort and sedation. Most intubated patients need continuous sedation. Common medications include propofol, Presidex, or midazolam. Some may also need paralysis with medications like cisatropium. Here are some ongoing complications to monitor. Ventilator-associated pneumonia, VAP, barotrauma from high pressures, tube displacement, cuff leaks, ventilator dysynchrony. Here's a pro tip. Always have a bag valve mask at the bedside. If the ventilator alarms and you can't quickly fix the problem, disconnect from the vent and bag the patient manually while you troubleshoot. Now, I know this seems like a lot to remember, but here's the thing about intubation. Intubation is one of those procedures that separates good ICU nurses from great ones. It's not just about knowing the steps, it's about being calm under pressure, anticipating needs, and being an integral part of a life-saving team. Let's quickly recap what we've covered. Intubation is inserting an ET tube to secure the airway. We intubate for respiratory failure, decreased consciousness, airway obstruction, surgery, and cardiac arrest. Your role includes preparation, monitoring, positioning, and medication administration. Confirmation is critical. Use multiple methods. Complications can be life-threatening but are manageable with proper preparation. Post-intubation care requires ongoing vigilance and monitoring. I want you to remember something. Every time you assist with an intubation, you're literally helping to save someone's life. That patient's family is counting on you to be at your best, to know your stuff, and to be ready when it matters most. My advice? Practice these skills. Know where your equipment is, understand your medications, and never be afraid to speak up if something doesn't look right. In the ICU, your voice and your expertise matter. If this video helped you understand intubation better, smash that like button. It really helps other nurses find this content. And if you want more critical care nursing education that could literally save lives, subscribe and hit that notification bell. Drop a comment below and tell me, what's the most challenging part of intubation for you? Is it the preparation, the monitoring, or something else? I read every comment and often make videos based on your questions. And hey, if you want to dive deeper into mechanical ventilation, because that's what comes after intubation, watch out for my upload this coming Saturday because it's all about your mechanical ventilation. It's going to take your ventilator knowledge to the next level. Remember, you've got this. Every expert was once a beginner. And every time you learn something new, you're becoming a better nurse for your patients. I'll see you in the next video. Once again, this is NurseBrain, inspiring greatness one lesson at a time.